Today I'll be talking to you about update on the approach of management of rheumatic fever. And I'm sure you know the basics of rheumatic fever, so I really do not want to tell you what you know, I feel so. And we'll just try to see what are the newer advances or basically a newer understanding to the management of rheumatic fever. Other than I won't tell you what are the regular clinical findings and laboratory investigations and management, and I'm sure you are very updated with all those things. Oh my God, what happened? If we see about the acquired heart diseases in children, you know, there are various kinds of acquired heart diseases, but amongst that, rheumatic fever still constitutes a major amount of acquired heart illness, and amongst all those acquired heart illnesses, you see rheumatic fever is 50%, and the others like myocarditis, dilated cardiomyopathy, Kawasaki, they are contributing the remaining 40% of the heart problem. So we still have to give a lot of importance to rheumatic fever as far as we deal with the acquired heart diseases in children. So why it is more important that carditis is the only clinical manifestation of rheumatic fever which results in residual permanent damage of the heart. So we need to really look into this carditis aspect very significantly. And another thing, virulence of rheumatic fever is directly related to the severity of carditis and what is the residual cardiac damage it creates. So what recent or the new thing as far as the prevalence is concerned, you know that it's virtually not existing in the developing countries. There are varying figures in India in different states, mainly because our socio-economic, educational and health status in different states is quite different. And therefore, we see it significantly coming down in southern part of India, but still quite common in the northern or northern part of India, and still a #1 acquired heart diseases in children. Now, if you see in the West, it has already become a hockey stick because it has come down and remained at that level. And in India, it's different; it's waxing, waning, coming up and down. So if you see actually what Shakespeare has said, that the past has become a prologue, that and only two true advances as far as the management of rheumatic fever are concerned, we have not gone beyond penicillin and steroids. So these are the only advances, and there are nothing beyond that is happening. So as far as we see the advances of rheumatic fever and rheumatic heart diseases are concerned, we have to see the advances in epidemiology, pathogenesis, diagnosis, treatment, and what we have done of prevention aspect of it. So if you see the worldwide data of rheumatic fever, it ranges from 0.05 to 0.7, 0.10, 0.9. In India, we are better than the maybe I call it as underdeveloped countries or African countries, but we are much less as far as the developing countries are concerned. Now, shall we start preparing for beginning for the rheumatic fever? Definitely not. Because if you see the incidence-wise, we still have 2 million people with rheumatic heart disease and 0.5 lakh people still get manifestations of carditis. So if you see the incidence of rheumatic fever in just a minute, incidence of rheumatic fever in India, approximately the incidence, the reference has been taken from one of our Indian context studies by Dr. Anita Saxena. The prevalence, the incidence is 0.2 to 0.75 per thousand per year for children. Prevalence is 0.4 to 21 per thousand in school-going children, and it still contributes around 150 deaths in developing countries. So it's quite a significant number as far as the mortality and morbidity is concerned. If you see the pattern of rheumatic heart disease in India, now it's becoming less prevalent. There are reduced number of hospitalizations, And if you see all the tertiary level centers in India, there is a progressive reduction in the number of balloon-matic phlebotomies and valve surgeries. School surveys are showing that there is a decline in the number of rheumatic fever and rheumatic heart disease. There is definitely a changing in the age profile, that we are seeing more of the older patients as compared to the school-going children nowadays. So, if you see the rheumatic carditis, the ethnic variations of it, the incidence of carditis in patients with acute rheumatic fever is around 40 to 99%. In the developing countries, there is the highest cardiac involvement. Carditis is affecting younger age groups. There are higher recurrences which contribute to progressive deterioration in cardiac function. And again, the reasons are genetic, maybe genetic susceptibility or socioeconomic factors. And these factors which influence the incidence of rheumatic fever, if you see, again, there are better living conditions, better access to healthcare, secondary prevention, and there may be a role of primary prevention of rheumatic fever. So, if you see the pattern of rheumatic fever and rheumatic heart disease, it's bites and names. So, what is recent and new? As far as the pathogenesis is concerned, whether we can identify the host susceptibility, whether virus acts as a helper, and is there any role of CD4 and CD8 cells. So these are the recent advances as far as the pathogenesis is concerned. We know that the agent is a good hemolytic streptococci, whether virus plays a helper role, whether environment has a significant role to play as far as whether there is a seasonal variation or climate change has any role, and there are benefits for antigens which play in the role of pathogenesis. Whether there are many things to be seen, whether there is a priming role for streptococcal skin infection or a viral infections which precipitate the attack of rheumatic fever. Now, if you see our own Indian data, we see there is definitely a female predominance when we see the incidence of rheumatic fever, whether they have a rheumatic fever, whether there is an increased exposure or definitely they have a access to preventive medicine and therefore they have a higher anything, because I see a lot of noise going on, I don't know. Hello? Yes. As far as the pathogenesis of rheumatic fever is concerned, unfortunately, there is no animal model and there is very readily autopsy material. So we just keep on assuming that it's something, but we really do not have a definite answer to this question. Now, if you see the pathogenesis, if you the patient has streptococcal pharyngitis, out of 100, one patient will develop acute rheumatic fever. Out of those patients who develop acute rheumatic fever, 50 to 60% develop definitely pyrethroid carditis, and out of these patients, 30 to 50% have permanent cardiac damage. 70% patients develop polyarthritis, and chorea is seen in around 2 to 10% of patients. Now, as I said, whether there is an immune injury which really play an important role in pathogenesis, we really do not know, and a role of CD4 and CD8 cells need to be really looked into, because they are responsible for breaching the endothelial continuity, some extraendothelial damage, which is responsible for rheumatic carditis. So, what is special in pathogenesis that why we need to see the enhanced role of cell-mediated immunity, because we need to see when we manage these patients of acute carditis, whether there is really the role of steroids is a major role to play, and is there any role of cytokine antigens to be looked into. Now, if we see the pathology of rheumatic fever and how we see the management part of it, the stage 1 is the executive stage, which lasts for 1 to 3 weeks. And during this stage, we really do not need any of the anti-inflammatory agents. Stage 2 is the proliferative stage, which lasts for weeks and months, and aspirin has a major role to play. And it is the stage C, it is a fibrotic stage, which lasts for months and years, whether aspirin plus steroids may have to give an in combination. So, as I said, rheumatic fever, the recent advances while the advances in diagnosis. When you say diagnosis, it's a clinical laboratory echocardiography, or if there are any newer modalities we consider for diagnosis of rheumatic fever. Actually, as far as the diagnosis of rheumatic fever is concerned, it requires a mature clinical judgment, laboratory support. Just a minute. And if there is any role of echocardiography to be played, we just need to see about all these things. So the step one, and as you know, when the Jones criteria were formatted, there were lots of updates in the Jones criteria, multiple times. First one was in 92, then was in 93, then 2000, then WHO modified again in 2004. So as we know that this major criteria and minor criteria, but the first modification was made when they said that there has to be a supporting evidence of group A beta hemolytic streptococcal, and that is by positive throat cultures and other markers for chronic acute inflammation need to be present. So this was the first modification in 1992. Then the second one was it was done by WHO in 2002-2003, diagnosis of rheumatic fever and rheumatic heart disease. And there they said the AAC recommended that there has to be two major or one major to two minor criteria. It's an antecedent step in streptococcal infection. They define the recurrence of rheumatic fever. For two major or two minor plus one major criteria plus antecedent streptococcal infection, then they define the recurrence of rheumatic fever, chorea, and incidence carditis. So, over the years, what is happening in clinical picture, the polyarthritis is remaining same, backpacking and waning. Carditis is definitely increasing. Subcutaneous nodules, chorea we hardly see, the erythema we also hardly see, and there were the criteria for epistaxis and pain in abdomen that we do not see much often. When we do the diagnosis, remember two major criteria is always better than one major plus two minor. Then arthritis and carditis are present, equivalent minor criteria cannot be used. Diagnosis of acute rheumatic fever is unlikely without supporting evidence of streptococcal infection. When we have asymptomatic carditis, then we should use echo guidance for evidence of mitral or aortic regurgitation. Anti-inflammatory agents may suppress full manifestations, so your clinical evaluation may have its all pitfalls. With history of rheumatic heart disease or acute rheumatic fever in past, one major criteria of arthralgia or high RCRP usually suggests a recurrence. So these are the points to be remembered when we make a diagnosis of rheumatic fever. When we see the follow-up at prognosis, permanent damage is seen only with carditis. Mild carditis usually disappears in weeks. Severe carditis lasts for 2 to 6 months. Permanent damage determines, actually, when you have permanent damage, that determines the prognosis of rheumatic carditis. Residual heart disease or lesion is influenced by three factors. What is the cardiac status at the start of therapy? If it is more severe, you are more damaged. Do we have recurrence of rheumatic fever because there is a addition of lesion and severity with recurrences? And recurrence of heart disease 10 to 25% 10 years after the initial attack. So you need to see all these points when you see the follow-up. And this is usually a good prognosis for elder age group, and there is no carditis during the initial attack. Carditis actually becomes a difficult diagnosis just if you stick to Jones criteria, because we do not have criteria for subclinical carditis. If you have absence of non-cardiac manifestation, it's really difficult to coordinate between the two. And if you have acute rheumatic activity on pre-existing rheumatic heart disease, active carditis becomes a little difficult criteria to diagnose. As we know, endocarditis is a diagnostic hallmark of rheumatic carditis. Involvement of mitral and aortic wall causing MR and AR are very common, and mitral wall involvement is seen is up to 95% of patients Aortic wall involvement is in 25%. Isolated aortic wall disease is seen in 5 to 8%, which is actually responsible for heart failure. But we do see a lot of patients who have tricuspid wall involvement, and there are two case reports where even a pulmonary wall involvement has been reported in patients with rheumatic carditis. Now, as far as myocarditis is concerned, actually myocardial involvement as a cause of congestive heart failure is rare. When we talk about congestive heart failure in rheumatic heart disease patients, it's mainly or only because of the endocardial involvement and presence of mitral and aortic regurgitation. Because in patients with rheumatic carditis, usually there is a less myocyte damage, the troponin levels are normal. If you see the heart function wise, you always have normal ejection fraction, fire fraction, shortening. Myocardial biopsy wise, there is no cellular myocardial damage, and there is no role in morbidity, mortality of rheumatic carditis due to myocardial involvement. Now, there is a big debate going on whether we should really involve echocardiography as one of the criteria for diagnosing rheumatic carditis. The problem with this is they are very objective criteria, and we need to train for echo readers and have very strict guidelines for diagnosis of rheumatic carditis and echocardiography. We need to have global collaboration for this, and it really will help in diagnosing subclinical carditis in patients with acute rheumatic fever. So, why there is a role of echocardiography in diagnosing? Because now what is happening, all the clinical diagnosis of rheumatic carditis depends mainly or only on evaluation of murmurs. We know patients who have acute carditis will have significant tachycardia, and we may not be able to appreciate murmurs better. And if you have Dopplers can diagnose even milder form of disease. So there is a big debate whether we really should involve echocardiography as one of the criteria for rheumatic carditis. Now there are a lot of things whether does echo perform better than a clinical evaluation. So actually it does not give earlier, this is a report from circulation, and it does not tell you that it does not give you earlier diagnosis, but may prove superior for diagnosis as compared to clinical evaluation. Again, it may not detect subclinical recurrence of carditis in the presence of pre-existing rheumatic heart disease. It may be echo again will not give you the answer. And as we know that prevalence of regurgitation in milder forms is usually exaggerated when we use echocardiography as a screening tool. So there are special criteria when we diagnose rheumatic carditis. What needs to be taken as a special criteria or specific criteria for rheumatic carditis? You need to have mitral or aortic regurgitation, but should be defined in two planes. And we should have either two or three criteria. Should definitely have a restricted leaflet mobility, focal or generalized wall thickening, and subvalvular thickening. So, as I said, mitral regurgitation needs to be picked up in two planes. The jet of the mitral regurg should be more than 1 centimeter in length and should go in the posterolateral direction, should have a mosaic pattern, and it should be a pan-systolic mitral regurgitation. So, whether it really will translate into clinical benefit, we really do not know. It is unlikely to modify the acute management of rheumatic fever regardless presence or absence of mild carditis. Now we really do not know whether it will influence the long-term prophylaxis when we diagnose somebody on echocardiography for presence of carditis. So recently, American Heart Association gave a report. It says that Dopplers may pick up trivial mitral regurgitation in otherwise healthy children also. And therefore, it is insufficient information at this stage to accept it as a major criteria for diagnosis of carditis. So, as I said, there is a lot of debate going on, and there are pluses and minuses. So, this is again a report by one of our centers in India. In patients with carditis, they picked up, like echocardiography, that is, they picked up mitral regurgitation in 100% of patients. aortic regurgitation in 27% of patients, and AR was always in combination with MR, and only AR was not seen in any of the patients. So, if you see the changes in the anterior mitral leaflet in rheumatic fever, you see mitral vein and thickening, prolapse, caudal thickening, caudal elongation, and fluffy. So, these are the different percentages which have been seen in this anterior mitral leaflet in the process of rheumatic carditis. Now, if you see just the picture, you see this a figure which has a thickened mitral wall, anterior mitral leaflet, and a mosaic pattern of mitral regurgitation which goes in the posterolateral artery, which is very classical of rheumatic mitral regurgitation. Now, what are the changes in posterior mitral leaflet in rheumatic fever? Again, it affects the mobility, thickening, caudal elongation, prolapse, and fluffy posterior mitral leaflet, and these are the different percentages that it is seen in patients with rheumatic carditis. This is again a typical picture of rheumatic mitral valve. So, if you see the criteria for and against to involve echo as the criteria for diagnosis, it has a high sensitivity, minimal missing, rules of other structural lesions, useful in silent carditis, may influence the duration of prophylaxis, but points against wise, it really has logistic problems. We may overdiagnose physiological MR for rheumatic carditis, and there is a possibility that there may not be there may be a non-uniform interpretation for diagnosis of rheumatic carditis. So, AAG has said in that it can increase sensitivity, but definitely may reduce specificity. So, what we can say, actually, it's a right tool. In the wrong continent, the continent where you do not see rheumatic fever, it may be a right tool. But in the right continent where we really see a high incidence of rheumatic fever and rheumatic carditis, it may be a wrong tool. So, it's very difficult to say at this stage. And this is one of the reports by one of our Indian centers, when we try to compare the rheumatic heart disease criteria by clinically and by echocardiography wise. So, if you see the second line, the clinically normal and echo abnormal were seen in 17% of the patients. So, they feel that echocardiography needs to be really included as criteria for diagnosis of carditis. So, this is one report from New England Journal of Medicine. So, if you see clinically, you can detect 2.2 cases per 1,000 children. When they screen the children suspected rheumatic heart disease. But the same thing when they tried to see on echocardiography, the incidence was almost 10 times more. There were 21.5 cases per 1,000 children. So, this is the report, and therefore this group says that it needs to be included as a diagnosis of rheumatic fever. Now, are there any other modalities which can diagnose carditis? So, there have been reports where radionuclide imaging was used for diagnosis, whether really endocardial biopsy will have any role to, like in suspected cases of rheumatic carditis, and it will diagnose myocarditis, like inflammation itself that we do not know. Whether MRI can give better tissue characterization for diagnosis of rheumatic carditis, that also needs to be looked into. Now, as far as the treatment is concerned, there are steps. Four steps. Primary prevention, where you need to work on eradication of Streptococcal, anti-inflammatory agents, aspirin, steroids, supportive management and management of complications, and step 4 is secondary prevention, that is prevention of recurrent attacks of rheumatic fever. So, prevention of rheumatic fever, preventing streptococcal infection itself, like is there any role for streptococcal vaccine? Whether the primary prevention is treating the streptococcal infection, secondary is preventing the secondary attacks, and tertiary is treating the rheumatic heart disease itself. Now, as far as the primary prevention of rheumatic fever is concerned, is the treatment of streptococcal infection, and you may be knowing better that the single dose of penicillin or penicillin B into oral penicillin can also be used. For individuals who are allergic to penicillin, you can give erythromycin or ethylsuccinate. So there's a big debate or discussion on role of controlling skin infection, whether they have some contributing role in etiology of rheumatic heart disease itself. So whether we should have community-based programs to reduce impetigo, because streptococcal skin infection may have a positive link with rheumatic fever. So this is a big question going on, and we need to look into the role of controlling skin infection in this situation. Another very big debate is whether primary prevention of rheumatic fever is missing somewhere, and this is a recent article from Circulation. What they say is secondary prevention can't reduce the incidence of new cases. So at our time, we see the patient have already established heart disease risk, and then we are preventing the recurrence as secondary prevention, but we are not preventing the disease itself. Valvular damage has already happened by the time secondary prophylaxis is started. So by and large, it does not alter the natural history of rheumatic heart disease. Actually, primary prophylaxis is the only way that it can reduce the incidence of rheumatic heart disease, and we need to look into the issue of cost and feasibility of doing this primary prevention in this situation. And in this study, they show that when you incorporate the primary prevention methods, you see the sudden reduction in the incidence of rheumatic heart disease, rheumatic heart fever in this subgroup. So what we need to do when we see the role of primary prophylaxis, we have to promote the source of diagnosis. And we don't need to go into the source cultures and those kind of tedious things. We have to start treatment within the existing primary healthcare. So microbiological diagnosis of group A streptococcal pharyngitis, usually if you really try to see in the community-based practice, it's not practical and not affordable. So we have to incorporate the role of systemic source screening program for treatment in schools and communities. So what happens in this program, the diagnosis is entirely made on clinical grounds. You just see clinically, you suspect bacterial pharyngitis and you treat them. So in these four protocols, what has happened, the need for source culture is completely eliminated. So if you clinically suspect throat infection or bacterial pharyngitis, do not go for microbial cultures, but just treat with single intramuscular injection of injection penicillin. In this protocol, educational campaign for medicos and paramedicos for treatment of sore throat is given much more importance than giving the importance to the laboratory diagnosis for a streptococcal infection. Then the thing came that whether it's really safe to give primary prevention in all the patients, because there is always the risk of anaphylaxis. If you keep on giving penicillin to all suspected patients of pharyngitis, there is a fear of bacterial resistance, and again, our living conditions and access to healthcare must improve. Then only giving penicillin may not really change the whole spectrum, but simultaneously all these things need to incorporate into the situation. Now what about vaccine for rheumatic fever? They are not close to phase 3 trials. The streptococcal community has not worked sufficiently collaboratively, and current understanding of immunopathogenesis of group A streptococcal disease is really crude to really have a vaccine for rheumatic fever at this stage. If you see the pathogenesis, the M protein is a principal virulence factor for rheumatic fever. And when we see anti-M protein antibodies, they cross-react with the heart tissue, and actually there is a fear that they can actually produce rheumatic fever rather than producing a vaccine. So we need to have a strain-specific immunity which protects against some episodes of streptococcal infection. So what WHO has given a statement recently that in the light of current lack of clear strategy for primary prevention of group A streptococcal infections, there is definitely a place for a safe, effective, affordable and practical group A streptococcal vaccine. Now what happens in India, because we have some attempts of starting the vaccine for rheumatic fever. We had 2 centers. And unfortunately, what happened, there were very few claims which were common to both the centers. And when we decide which are the patient groups at risk to whom this vaccine needs to be given, there are issues what age we should give. Should every vulnerable child need to be vaccinated? And which are the children at risk? So we really do not have identified these particular questions, and we don't know how to go ahead and whether the vaccine is a real answer for it. Then the next comes the supportive management of or treatment of rheumatic fever. We have specific criteria for bed rest, and they are guided by ESR. So these are specific recommendations. I think you may know about it. If you have only arthritis, mild carditis, moderate carditis, or severe carditis. And if you have severe carditis, your bed rest needs to be much prolonged, maybe definitely 2 to 3 months. We need to give restriction of fluids and sodium. Treat the congestive heart failure with diuretics, digitalis, and ACE inhibitors. Treatment of chorea needs to be given, and we need to give rest, joints, and supportive cleansing if required. As far as anti-inflammatory treatment is concerned, if you have only arthritis, aspirin we know we give in the doses of 75 or 100 milligrams per kg per day. Give at 4 to 6 divided doses. If you have carditis, then we may add prednisolone, which is 2 to 2.5 milligrams per kg per day. Give at 2 divided doses. Taper over 2 weeks. And when we are tapering, we have to add aspirin, 75 milligrams per kg per day for 2 weeks, and continue aspirin for another 4 weeks. That's a standard regime. So, I just told you about this dosage of prednisolone and aspirin. Which is give prednisolone in patients with severe carditis, start reducing 25% of a previous dose every week, and we have to concomitantly use salicylate to avoid the rebound. There are reports that of giving IV methylprednisolone in severe carditis, and there are some reports of even use of immunoglobulin in patients with active carditis. Actually, immunoglobulins do not alter the extent or severity of carditis or decrease morbidity, so its role again is very controversial. Now, as far as anti-inflammatory agents are concerned, there is a very controversial role of steroids, as we know. And there were 8 randomized trials which involved around 996 patients. In that, they had a lot of steroidal agents, and IV immunoglobulins were compared with aspirin. They found no difference in the risk of cardiac disease at 1 year between steroids and aspirin. And there was no benefit using corticosteroids or immunoglobulins to reduce the risk of heart valve. So the role of steroids remains very controversial. So the recommendation was it still can be used in very sick patients with pericarditis or significant congestive heart failure. But again, there were no significant benefits over aspirin. No proof to tell that they lessen long-term complications of carditis. The only thing what happens is that they definitely do result in rapid resolution of acute sanitization, and newer murmurs or pericardial rupts do not appear when patients are on steroids. So, if you just try to correlate the pathogenesis of acute carditis and steroids, there is a beneficial role in the proliferative stage. There's enhanced, as you know, that there may be an enhanced role in the T-cell mediated wall injury, and that the steroids may have a role. But 50 years data is consistently against steroids, and but again, this was a pre-echocardiography era, and we really do not know the pros and cons about that. But as far as the murmurs are concerned, at the end of 1 year, you see the steroids are better in reducing the incidence of murmurs as compared to aspirin. So when to switch aspirin to steroids? You start aspirin if you have no response within 3 to 4 days. You start or switch over to steroids. If you have newer cardiac findings which develop when patients still are on aspirin, if the patient develops significant congestive heart failure, or the child is intolerant to aspirin. The newer modes of treatment, whether as I said, the controversial role of IVIG, valproate for chorea, with the anti-cytokines may help, or is there any role of other non-steroidal anti-inflammatory agent or methylprednisolone for control of active carditis? We don't know. So again, I said there is a controversial role of IVIG in patients with rheumatic fever. The other issues are a use of decoxin, because again, whether it's needed, we don't know, especially when we know that the underlying heart function in patients with even active carditis is absolutely normal. When they are in the acute phase, there is a risk of arrhythmias. So the role of decoxin is very controversial in patients with active carditis. Use of ACE inhibitors is a standard practice. We can use diuretics and other inotropes as and when required. The next thing is whether a surgery can be done in patients during the acute stage. As we know that if the patients have significant cardiomegaly or congestive heart failure, it's very unlikely that it is second to myocarditis. Most of the time, or always every time, it's endocardial damage and secondary to severe mitral regurgitation. So, in patients with severe mitral valve disease, severe mitral regurgitation, congestive heart failure with an intractable hemodynamics, in acute stage, a surgical repair replacement of the mitral valve is indicated. So, secondary prophylaxis is actually a recipe for preventing the comeback. So, it's not a treatment, but it's just a recipe for prevention. So, secondary prophylaxis is a continuous chemoprophylaxis to prevent recurrence in a patient who had an initial attack of rheumatic fever. We know the commonest drug what we use is benzathine penicillin, a single dose, or oral penicillin, or sulfadiazine. In very rare patients who are allergic to penicillin or sulfadiazine, erythromycin can be used. Now, the major thing that how long we should continue this secondary prophylaxis, so there are specific recommendations for that. If you have rheumatic fever with carditis and residual heart lesion, you have to give at least 10 years since the last episode of rheumatic fever, and at least until the age of 40, sometimes in some patients even lifelong. If you have rheumatic fever with carditis but no residual heart damage, is due for 10 years or well into the adulthood, whichever is longer. Rheumatic fever without carditis, you can give up to 5 years or up to the age of 18, whichever is longer. So these are specific recommendations by American Heart Association how long we continue the secondary prophylaxis. Now, if you see the incidences of rheumatic fever recurrences, they are least when the patient is on parenteral penicillin, they are highest when the patient is on oral penicillin, and oral sulfadiazine is in between. Now, problems of giving secondary prophylaxis in India, the compliance is a major issue, and we see compliance in around maybe 40 to 80% of patients, but there is a drop-off of around more than 20% of patients. Sometimes, as you know, that many times it's not available. There is a fear of anaphylaxis and the patients don't get in many centers because people are not ready to give it. And the last one is identifying the candidates who really need it. So, as for the strategies for prevention, we really need to go beyond secondary prevention, and most public health and clinical approaches with rheumatic fever and rheumatic heart disease, they originate from the research program. So, plan-wise, we need to have better understanding of disease pathogenesis for improving diagnosis and treatment, identify people with rheumatic fever earlier, and implement an effective approach to primary prevention. So, these are the plans or strategies which may help in preventing the incidence or reducing the incidence of rheumatic fever. And this is a very new African approach to rheumatic heart disease control, which is called as the ASAC. So, A is advocacy, surveillance, awareness, and prevention. And what they really say is a very important thing, that most control programs can be run for a fraction of cost which needed to perform a valve surgery in patients with rheumatic fever. So, it's very important to stick to or adhere to or try to put this ASAP protocol in our management system. What they say is we need to have a rheumatic heart disease registry data which will help us in understand the disease outcomes. We need to track the mortality, morbidity, level of heart failure, severity on echo, recurrence of acute rheumatic fever, distribute the information as far as the outcomes of all surgeries are concerned, presence of carditis or chorea on prevention, level of adherence to benzocaine penicillin. In fact, one of the things which they suggested was really very good. Now we have mobiles with everybody. You have a data of all the patients with rheumatic fever on your directory, and you know when they are supposed to be getting the next dose of benzocaine penicillin. Just one day before you send them a message that tomorrow is your date for taking your benzocaine penicillin. And even this kind of a small thing which if you incorporate into the system, there is a high chance that at least you will prevent or reduce the recurrence rate of rheumatic fever. So in that we have to allocate the responsibility to even primary healthcare staff. People should not wait for injections because in that whole thing we see a lot of dropouts. Track the patients to continue prophylaxis. One of the methods is either email or a mobile phone, send them the messages. You should not ask them to come to you. Rather than that, you should go to them so that again adherence to the prophylaxis is better. So rather than they coming to the primary healthcare centers or the medical centers, you go to homes and schools and give the benzocaine penicillin prophylaxis. And again, one of the dropout or non-adherence is mainly because of the severe pain which creates during the benzocaine penicillin. You know that we need to use a very wide bore needle. So pain minimizing injection taking to kill put into the system, there is a high chance that adherence will be better. Then the second thing is you have to monitor the quality of benzocaine penicillin G. You see to it that there is a consistency of supply. Many forms of benzocaine penicillin, there is no adequate serum levels after 28 days. So see to it that you have to give them between 21 and 28 days. So there is another thing which will really help. There is a work going on for carditis implants. There are implantable forms of benzocaine penicillin. So rather than taking this painful injections or this skin disease, if you have these implants, whether they will have a better adherence and it will help in reducing the recurrence risk of rheumatic fever. That also needs to be listened to. Now the next one is we have to identify people with rheumatic heart disease earlier. So as I said, preventive measures have a higher chance of success rather than curing them. More new patients have already significant valvular heart disease, so therefore we have to work more on preventive measures for acute rheumatic fever. If you really adhere secondary prophylaxis to people with mild carditis, which results in no detectable heart disease 5 years down the line. And the only way to identify the patients with rheumatic fever or the recurrences is continuous screening. Then we really need to work for better understanding of the disease. The studies of immunomodulatory agents develop diagnostic tests for acute rheumatic fever, which rely upon relatively few tests of antibodies. Actually, nowadays they are just relying on the antibodies to cardiac antigens. So we need to have some specific diagnostic tests for diagnosis of rheumatic fever. And we have to recruit actually the acute rheumatic fever cases to study the immune responses or immunological status for these patients with rheumatic fever. So we really need to work on better understanding of the disease. Now, whether there are any genetic factors, so if there is inherited susceptibility to acute rheumatic fever, there is still now no attempt to see the genetic marker. We have to use the modern techniques to determine if there are areas of human genome with polymorphism highly associated with rheumatic fever or rheumatic heart disease. This is the area which really lacks as far as further progress in this form is concerned. If we have subclinical carditis, what are the implications of diagnosis? Whether echo can help? How do we manage? Whether steroids have a role? Whether we can talk something about prognosis depending on the subclinical carditis and what is the duration of the prophylaxis. So just subclinical carditis is a major area where lot of emphasis is given nowadays and the work is going on. We know prevention is better than the treatment of rheumatic fever. Healing rate of rheumatic carditis is remarkably high if recurrences are prevented. If rheumatic fever becomes progressively milder, rheumatic heart disease should follow corresponding patterns. And actually, if you just try to treat the rheumatic fever part of it, there is no much treatment beyond aspirin and steroids with balm for the bite. So at the end, as I said, rheumatic fever is a Shakespeare's redefinition. If you see the diagnosis of rheumatic fever is actually a comedy of errors. Diagnosis, as you like it. In treatment, much to do. And in eradication, a mixed nice journey. Thank you very much, all right. Hello. You can plan for surgery in actually, I don't know the answer for this, but there is they specifically have said that if you have intractable hemodynamics in spite of adequately treating the congestive failure part of it, you can do the surgery at any period of time in active carditis. So we don't really need to wait for the carditis to resolve because it will not resolve. So you can actually do when the patient is on treatment.